Hi, I am PK Srivastava, working as Joint Director in National Vector-Borne Disease Control Program under Ministry of Health and Family Welfare, Government of India. I am working for elimination of lymphatic filariasis, which is targeted for elimination in the country by 2015, and globally this disease is targeted for elimination in 2020.
Now, when we want to implementation, we must understand what is our strategy and how to start the implementation right from the grassroots level. Now, the strategy of the program is interruption of transmission by giving single dose mass drug administration, and to do this we must know the magnitude of the problem in the area. Now, to have the magnitude, we have to map the filariasis cases by knowing the endemicity. Now, the best course of doing this mapping is line list all the lymphedema and hydrocele cases in the country. There have been efforts since 2004, and line listing has been every year updated by visiting door to door through the grassroots level workers. Then, to know the impact of the program, we do the night blood survey to assess what is the microfilaria prevalence after the round which have been done 1 year before. This shows the impact that whether microfilaria percentage has come down in the society. Now, to have the implementation plan, we must have a calendar of activities. The calendar of activities starts with meetings to decide plans. We should have the advocacy campaign. We should have a training and workshops for improving the capacity of the health workers from the health sector as well as the people involved from the non-health sector. Then there has to be availability of the tools like drugs. We have to maintain the chain. We should have the quality assurance of the drug. We should have adequate BCC-IC material. We should identify the drug distributors who will do the drug distribution to the community for administering them. We should have formed the team, and they all should be explained what is their job so that they understand the whole thing fully. Now, to update the line listing, the worker has to be trained in such a manner that last year record he takes with him or her and then enumerate it. While updating, he may find that there are some addition in the family members or there are some deletions. This is very important because when they go for supervised drug administration, they have to visit house to house. The strategy also recommends supportive by establishing some booths like railway stations, like bus stand, like schools, like some good picnic spots or hot spot. But the main strategy remains house to house or door to door visit by the local health worker who has been assigned. And one worker has to have the quota to administer drug to 250 persons, which is usually present in 50 houses. In case of side effects is noticed, we should have a plan of rapid response team located at PHC or CHC, that is community health center or primary health center, and their phone numbers and their location should be known to the drug distributor team in that area so that in case of any problem they can directly talk or phone and they can take the patients for remedial issues. Now, sometimes you see that during the course of drug administration, people are not there. So, to cover them, there is a mop-up activity. That mop-up activity is generally recommended for 2 days, but it can always be extended for 7 days. And during 2014, this is specifically has been taken care of, and that is why from Filaria Day we have resorted to National Filaria Week. Now once we have done the MDA, post-MDA activities are very important, where we have to assess ourselves how far we have performed, whether it is satisfactory or it is not satisfactory. If it is not satisfactory, we must take necessary action and improve the coverage, maybe by extended catch-up round or extended mop-up round in that area where from either reports have not come or there has been very poor compliance. Once that is also done, there has to be review during post-MDA by District Coordination Committee, and once everything is over, then we should involve the medical college or the regional office of Government of India, some outsider to come and assess our work, for which also there are set pro forma and set guidelines issued by Government of India. Now, if we start our first step, that is morbidity survey, how to do the line list? We identify the lymphedema or hydrocele cases in the community, either by noticing them or by inquiring from the key respondents, and this will help us to know that which area is having more disease. Since lymphedema is easily recognized, this can be easily obtained. But for hydrocele, yes, people they will try to hide or they will be shy. So we have to ask from the other patients. There are questionnaires. There is a key informant questionnaires which can always be used for knowing or gathering this information. There is very simple pro forma to line list, which includes only name of the patient, his or her age, since how long they are having this swelling, maybe 2 years, maybe 5 years, maybe 20 years, whatever they tell, that with their memory you have to write. Then whether they are male or female, then their address, and this information can be sent to the concerned primary health center, where the lab technician, like usual data compilation, he does it, and from there onwards it is circulated as number of patients with lymphedema or hydrocele in the subcenters wise to the PHC, and then at district level it is compiled at PHC wise, and from there it is sent to the state headquarters and the regional office of Government of India with a copy to national headquarters, where it is compiled district wise for the whole country. This is not required only for those districts which have been selected for MDA as endemic districts for LF. It is also necessary that we must gather this information for all those 9 non-endemic districts. It means from all the 640 districts of the country, we should have this information, because even if the patient is outsider, even if the patient is known as imported, even if the patient is known as migratory, he or she has to be provided the relief from this disease, and they must be trained how to do. Now, once we do the mapping, we must be able to show, and we must be able to monitor our work. For this, we must show in the map that in the PHC, in the subcenter, the villages have surveyed and found positive with the red color. The villages surveyed found negative, that is without any case, is shown as green color, and the villages still to be surveyed shown to be grey colored. But I am confident that now, after 9 years of the program, 10 years of the program, it is over, and maybe few villages are still unsurveyed. which should be completed within 1 month with the help of the Ashas or Anganwadi, and PSC medical officers can be responsible for this, where it can be completed maybe within 1 month or 2 months' time. Now, beyond line listing, we have to have a micro action plan for village sub-center at PHC level. These plans should be available at PHC to monitor the movement and the activities being done within the jurisdiction of the PSC. Similarly, for urban areas, it should be available either with urban health officer or urban corporation, and both these plans should also be available at the district headquarters, so that combining these two plans, the district plan is made as a whole. And then at the district level, there should be a nodal officer who will monitor all these activities with the calendar, whether it has been done or it is being done as per schedule. If there is any delay, he should try to resolve the issues for the delay and see that it is done within the next 24 hours. Then there are state level meeting as per guidelines. There has to be state task force meeting. There has to be state technical advisory committee meeting. There has to be district coordination committee meeting at the district level. And there has to be a series of sensitization meeting, including press and media, for improving the capacity of the people who will deliver the goods. You have to have series of training at the state level, at the district level, for the medical officers, for the paramedical, for the microscopists, for the drug distributors, and for the zonal officers who usually cover 3 to 4 districts, and they must know every steps of the MDA campaign. Now, besides the supply of drugs from the state to the district, it has to go till the PHC. And before distribution, ideal situation is that they must have the level of stock, the number of batch, the number or name of the manufacturers, and all the records which are required in case of any exigency, it can be quoted. So that supply maintenance chain is to be maintained with the requirement of each individual worker. And in the program of Filaria elimination, the DEC tablet strip has been designed in such a way that it helps. Like one worker who is covering 250 persons, he should have the tablet roughly around 750. So the strip is made in such a way that 3 tablets on one side and 10 tablets on one side makes one strip of 30 tablets. Now 25 strips of such tablet make 750 tablets. These are kept in one box with all kind of marking that whom to give, whom to not give, with a dose schedule also. Now this helps the drug distributor to keep one box only for his or her quota, along with 250 or 300 albendazole to the maximum.